Okay. So, do I get my slides? I hope so. My disclosures haven't changed in the past 60 seconds. Okay, so the rebuttal. I want to address a couple of issues, and one is this, Averroes, because it's a point that I think is really important, and I'm not sure everybody appreciates it. If you look at overall bleeding rates between apixaban and aspirin in the so-called contraindicated patients, the overall top-line results are not much difference, hazard ratio 1.13, right? Not much different. But remember, this was an ITT analysis. If you look at the actual on-treatment analysis, meaning if you throw out the patients who actually didn't take the apixaban and looked at the patients who took apixaban or an aspirin, it's actually a 54% higher rate with a p-value of 0.07, okay? So there is more bleeding. And who are these patients? OAC contraindicated? Well, and this is of course impossible to read. Let me just point out one thing to you. It was 8% of, no, is it 8? Yeah, that's right. Overall, it was only 3% of patients had serious bleeding during VKA as the reason they entered the trial. Okay, the majority of these so-called contraindicated patients didn't have very strong contraindications. Why does that matter? Well, let's look at some recent data, Apache and SOSTAR. These are smaller trials, but they're very interesting trials. Published in this most recently in Lancet Neurology, Apache AF randomized patients with intracranial hemorrhage to either apixaban or not. And what you see is the overall composite endpoint was no difference between groups. But what's interesting is, let's look at the individual components. Ischemic stroke rates, apixaban, no apixaban, 12% in both. The hazard ratio is 0.97. Basically, it's 1, no difference. And if you look at intracranial hemorrhage, actually, yes, it's higher. So apixaban, when used in patients who are high risk, not used in low risk patients, but in high risk patients, actually worsens intracranial bleeding. Not a terrible surprise, by the way. Same thing in SOSTAR, and I'll just focus you on the on-treatment analysis because I think it's the most relevant. If they took it, there were more recurrent intracranial bleeds than if they didn't take it. And I don't think that should come as a surprise to people. Now, of course, you're going to say, okay, that's all fine and dandy, but show me the data on appendage closure. And I wish I could. I wish I could show you a randomized trial right now. And as many of you know, we tried to run ASAP2. We didn't get very far, and the trial was stopped because of futility, because we couldn't enroll patients. We couldn't enroll patients because there's an abundance of non-randomized data that indicates that appendage closure does work in these patients. This is a really nice meta-analysis by Jens-Erik Nielsen-Kusk, looking at patients who underwent appendage closure in dotted line versus standard of care. And what you see in these ICH patients is that those patients that underwent appendage closure had fewer of the composite endpoint, 80% less ischemic stroke, less bleeding, of course, and also 90% less mortality in this very specific population. What about randomized data? There are a couple of other trials that are also not enrolling that quickly, is my understanding. I'm hoping that at some point we'll be able to combine the data from all of these and put something together and make a reasonable conclusion. But this is what we have right now. The other thing I always hear is, well, listen, once you start doing appendage closure, you're going to start doing it in everybody. You do it in people that are walking down the street. Let's look at who actually is receiving appendage closure. And this is the appendage closure registry, and these are the randomized trials. The appendage closure patients are actually older than what we did in the randomized trial, 76. That's a pretty old population with a CHAS-VAS score of 4.6, where 30% had a prior stroke and 70% had previous bleeding, of which 12% was intracranial bleeding. So these are not low-risk patients that are receiving this device. And I don't think these data have changed. There's a recent abstract looking at these patients, very similar. So I think what I'd like to say is that maybe less is not always the best approach. I think appendage closure is safe and has become safer. It certainly seems to be effective. And again, I don't think one can poo-poo the mortality benefit. It's something that we've seen on different therapies. When you get rid of bleeding, you reduce mortality. And it's economical. And it's fun. So in the spirit of continuing to be good colleagues, I'd like to read this to you. John, let's agree to respect each other's views, no matter how wrong yours might be.